Grivas, how can we ensure that a patient's geographic location doesn't dictate the quality of care that they receive?
Very important question for sure. And I think, as you pointed out, we have touched upon this before, but I think there is definitely much more to be said and done. More importantly, I think the location has to do with multiple different, again, social constructs, right? The location and the distance from a cancer center with expertise is one thing. The time needed to get to the cancer center is related to that. And also the social support that the patient may have. If, for example, a particular treatment, for example, a clinical trial requires a weekly visit to the cancer center, is that a feasible thing for the patient who lives, miles and miles away in the rural areas of Oklahoma or somewhere else? Can we design clinical trials that are more friendly to these scenarios, right? That require less frequent visits? Can we provide, if possible, funding for housing closer to the cancer center? And there are examples of cancer centers doing that. They provide, a temporary housing, for the patient to be able to be close to the cancer center, so they don't need to worry about going back and forth, across the state lines sometimes. The other thing, of course, is insurance coverage. And again, this can have some relation to location. And it's something we have to think about. How can we help our patients who have significant copays because of the particular insurance at that location being supported, by foundation or other funds that the cancer center or the state or, again, other foundations may have. The other issue is about access to diagnostics and treatments. There has been some, interesting discussion about particular prostate cancer, about access to what we call next generation sequencing, which is a diagnostic test aiming to profile or fingerprint the cancer DNA to look for particular mutations that the cancer may have that may lead to particular treatment options. If, for example, a mutation A is present, can we use a drug X that might be relevant in that context of that mutation? And recent data that was presented at the ASCO 2021 showed that if you look at those mutations, they are not very different, between, for example, white and black patients. There are similar types and frequencies of mutations. What is different is access to the test, and of course, access to the therapy related to the test. So I think we have to do a better job bringing ourselves to the community, extending, our opportunities to the patient to get connected to the healthcare system, and they'll build bridges to bring the patient closer to the cancer center, offering those tests. Work, with patient navigation to help patients understand the significant value of the follow-up, but also provide them with, in a way that is equitable, access to diagnostics and treatments.